platform and direct insights from those persons who use the telemedicine platform to better hinterland access for our public health system. Our aim was quite a simple one. We wanted to see if our telemedicine program that we began in 2022 actually did what it set out to do, which is bring healthcare to remote hinterland communities. Because our system in public health heavily relied on medical evacuations and travel access for remote communities to have emergency and urgent care, the government thought that there was a gap that existed in early response. And the government then partnered in 2022 with the telehealth company 19 labs to make sure that these gaps were addressed. The rationale was simple. We wanted to make sure that our hinterland communities had ready access to care. So delays in healthcare and high cost, of course, would be somewhat reduced. What this tells us is that our objectives focused on the short-term impact, because we've not yet reached that 5-year mark, the cost effectiveness and patient satisfaction, as well as user satisfaction of the program. Our methodology was mixed. We used a quantitative as well as qualitative approach. At the time of this study, the period being 2024 to 2025, we had 8 to 1 telemedicine sites. I believe you would have heard the minister speak this morning on the update since then, which surpasses 100. We used data sources from 19 labs, regional health services, as well as health records available in the hinterland communities. Qualitatively, we looked at the amount of medical consultations that were materialized on the telemedicine platform, the number of medical evacuations, and of course, the cost analysis. Was this effective to our geographical plane or not? And qualitatively, we wanted to look at what the experiences were on the ground, some of the barriers, some of the challenges. We attained ethical approval from our IRB board. So during the period of 2024 to 2025, we recorded just over 14,000 consultations on the platform. Majority of users were females between the ages of 25 to 44, which reflected just about 58% of the users. Interestingly enough, the cases in 2024 that predominated the consultancy platform were the pediatric cases, and in 2025, we found that the chronic disease cases far surpassed that. All in all, there was a 74.7% reflected over the 2 years of early access to care reported. In 2024, we actually reported a 31% early access to care. So the medical evacuations, how did they do? We found that in 2024 and 2025, during that period of study, there were 834 cases managed at the local health facilities where the telemedicine sites are. And that means these cases were managed by the community health workers in consultation with doctors or specialists from the tertiary institutions, which were very far from the telemedicine sites. Notably enough, there was also a 26.4 reduction in medical evacuations. But not only that, telemedicine, and although we don't have it on this slide, proved to identify the need for medical evacuations. Of the 70 persons evacuated during the period, about 4 of them would have died if there were no telemedicine consultations available. So the cost effectiveness reported at 70.3% over the course of 2022 to 2025 November in gross savings as return for investment. And at that time, we did see that there was still a net loss of just 29.97%, which we project by August 2026, those costs will be fully recovered by use of the platform. And of course, we had some challenges. Unfortunately, we can't control the climate, the low cloud cover, the mountains. Those are things we cannot move. And those affected the connectivity in about 4 to 5% of the sites. There were also poor power connectivity issues in the hinterland region. And for the advanced equipment mentioned earlier in the morning session, we use the telemedicine sites to diagnose through AI technology. So there's some sites with ultrasound, x-rays, and we recognize that as a challenge, although that was implemented in late 2024 as a challenge, not many sites have access to it. That program is still expanding. Overall patient satisfaction was recalled at 92%. Overall provider satisfaction with the program was recalled at 97% thus far. In conclusion, we've recognized that the innovation holistically does improve the quality, efficiency, and early access to care. It reduces the cost of medical evacuations and also influences timely access to urgent medical evacuations. And of course, it strengthens the confidence of those community healthcare providers to provide care with the support of a specialist or a medical doctor who's just on their device guiding them through on how to manage that patient. There were some limitations, however. We recognized that there was a relatively short period of investigation. We just looked at 2024 to 2025. And again, at that time, there were just 81 telemedicine sites. We recognized that by the end of 2026, whereas where we have scheduled a longitudinal study to be conducted, we would have a wider picture of what the impact has been. Also, there's deficient data, and to date, we're trying to fix this on the movement of personnel. To have the equipment installed in some of the hinterland remote facilities, we would have had to train personnel to use the equipment, and we had no record documenting that cost per se. We also had a limitation with documenting out-of-pocket patient costs. The idea for telemedicine is to move away from having care be traveled access to it more be consultation and connectivity access. For future studies, we're looking forward to conduct a 5-year impact study, which will show more variables. I have to acknowledge the support and leadership and guidance of our Honorable Dr. Frank Anthony, who is the co-author on this paper, along with yours truly, 19 Labs, who give us access to their platform and helped us with the cost benefit analysis, the regional health services, and of course, the healthcare workers who participated in phase 2 of the study, focusing on the survey. For more information, you can scan the QR code and the full manuscript will be revealed.
Thank you very much, Dr. Scott. Much appreciated. Open the floor to questions. I will allow 2 questions, please. Go ahead.
Thank you, Piedad Huerta Pajo. More than a question, allow me to make a comment because I think that this is great. I think that I congratulate Guyana for the initiative and for doing the research, doing the documentation and confirming that this is a very cost-effective way of providing services to the community. But also, even though you are documenting the cost benefits in monetary and percentages, I think that those 4 lives that were saved, they have no value. It's unvaluable, actually, a great value, I must say, in better English. So thank you and congratulations, and thank you for sharing with us this information.
Thank you.
Dr. Scott, can I ask one more question?
Sure.
I'm curious if you could give us any idea of why you think the number of evaluations went down from 2024 to 2025.
Evacuations.
Evacuations, was that right? Okay. My mistake.
Because we were measuring, there was a slide that I indicated that from 2020 to 2025, November, which was the study period, the medical evacuation spanned before. So we did our baseline.
Okay.
And we recorded 2,800, I think, and 80
Oh, okay.
medical evacuations, as opposed to the study period, which just recorded 70. The study period was well over a year, and for a year in Guyana, in those hinterland communities, those exact communities, you would have just about 150 to 210 medical evacuations, and that spanned over the course of about 3 years. We had data electronically from 2021 and to 2025 on medical evacuations. Before that period, we pulled it manually. And so
I
when we did the comparison, we recognized that the community health workers that would usually have to refer patients to a regional or district hospital or even the tertiary referral hospital no longer had to do so because they had the doctors on their devices. They were just ringing a call and then they'd get how to manage the patient.
Sure, that's helpful.
Thank you so much. Appreciate it.
Thank you.
All right, our next presentation is going to be from Dr. Kim Quimby. Is Dr. Quimby here? Great. Dr. Quimby is a senior lecturer at the George Allen Chronic Disease Research Center at the Caribbean Institute for Health Research at the University of the West Indies. Her presentation today is entitled Conceptualization of the Innovation to Industry Framework to Facilitate Commercialization in Universities. On to you.
Thank you very much, Chair, and thank you very much, colleagues. So I'm presenting on the behalf of the CARPHA Innovation Team. And the background of this research, oh yes, okay. And the background of this research was from the Barbados Diabetes Remission Study 2, which was a low-calorie dietary intervention for select persons with type 2 diabetes. They would go on a low-calorie diet, come off of their diabetes medication, they would lose weight, and then they'll be able to stay off of their diabetes medication as long as they kept the weight off. So this was going fine until COVID-19. So the backbone of the low-calorie dietary intervention was a commercially available shake. And during COVID, we weren't able to get the shakes from the distributors and we weren't able to deliver them to the patients. But we had persons already in the program, we didn't want to stop. So I got together with a dietitian. We basically asked them, what is it that you have in your cupboards, in the ground that you can dig up in your fridges? And we started to make these meals and shakes from whatever produce they had. And then we thought, well, patients liked it, it worked, this is a good idea, so maybe we should commercialize it. So at that point, the commercialization process was taken over by the senior administration at CARPHA. They signed a deed of assignment with the inventors, which is myself and the nutritionist, and a licensing and distribution agreement with Pine Hill Dairy, which is our industry partners. Once industry became involved, they then had to secure the necessary raw materials because we were using fresh produce. They had to use pulps or powders to get the right consistency all the time. So we had to undergo further reformulation and taste testing. So this is year 6 since the end of the project. And we're hopefully, right at the cusp of going into commercialization. So the aim of this particular paper was to formalize the lessons we learned during that time into a framework that guides the process from innovation to industry. So in the background research, I was looking for a framework and I found this conceptual framework on managing technology commercialization in universities. And it looks at these 8 domains: the role of the academic entrepreneur, the role of the research of technology, the availability of market and finance, intermediary support like the tech transfer office, the role of the collaborative research center, policy support, and regional infrastructure, and the impact that this would have on commercialization. The problem with that framework is that it was too narrow. It didn't really consider the role of industry. They thought about the university wanted from industry, but not what industry itself really brought to the table. And it was too static. It didn't consider the interaction between industry and academia. So to fill this gap, I engaged with the major stakeholders, which was the university and the folk at Pine Hill Dairy. And I asked about the barriers and facilitators for between stakeholder engagement. That is, what each person brought to the table and contributed to the process. I also asked about the barriers and facilitators for within stakeholder progression. That is, what each person thought they needed to become in order to engage freely and effectively. And I termed that the inner setting or the internal environment. I also reviewed documents, policies, operation reports for anything on the external environment that might impact this process. So this is what the conceptual framework looks like once it's populated. So you can see the internal environment with the academia and industry and what they bring to the partnership, either the innovation or the market share. You see the barriers, the facilitators, and the needs, and you see the external environment on the outside. So we look at each one in turn. Wow. Right, so looking at the facilitators at the point of academia, they were knowledgeable and engaged academic entrepreneurs. So myself, I'm a clinician scientist, and the other partners, a dietitian chef. So we are well able, we have the expertise, the capability to formulate shakes that are of the appropriate caloric and nutrition content. There was market availability and readiness. So actually Pine Hill was actively trying to fill this gap, but they were unable to do so. So when we brought the product to them, they were very happy to participate. We didn't have a tech transfer office, but we did have the intermediary support and relevant expertise by just grabbing persons from different faculties and different departments. We had expertise in intellectual property, in licensing, and in business negotiations. There's clear policy in the University Blue Book, which is the ordinances of the university. And it outlines, it's very clear, on the profit sharing between the university and the entrepreneurs. And this project is in line with the UWI AAA strategy for 2022 to 2027, which is the revenue revolution. They're all about making money, and this is something that can potentially make money. So the university was very happy to participate. So looking at the barriers, the lack of the tech transfer office was a barrier. Even though I said we had the relevant expertise, in the beginning, we were very unaware as entrepreneurs of how to connect with industry and the rights and the rules surrounding IP. Even though it was in the Blue Book, we've never read the Blue Book. We never had any reason to. So we weren't quite sure of who to reach out to and how to get things going. There was no dedicated team, so a lack of human resources was a problem. As I said, we just took persons from different faculties and different departments, but this work was on top of our clinical duties, on top of our research, on top of our administrative duties, and it really just became a bit much. And there was lack of finances. There's no dedicated startup fund for entrepreneurship, so this was injected into the university budget, which made the bursar very nervous. So the needs what we thought we needed is to progress from individual silos to a bilateral relationship with industry, an ongoing relationship. And I have that in bold because industry also said the same thing. From the university side, we also would like to have tangible support from the government on select projects that align with their agenda, and not just a pat on the back and saying, yay, this is really great. And what would be useful for us as the entrepreneurs is a pathway to industry curriculum or toolkit. Because as I said, we kind of learned as we went along, we kind of floundered and kind of found our way through. But if there was a particular toolkit, entrepreneurs who are coming up would find it much more easy to go through the process. And then we should advance to the side of industry. So looking on the industry side, okay, the facilitators there had were pre-existing relationships. So they had relationships with Tetra Pak, who does their packaging and their formulations. And they also had pre-existing relationship with UWI. In fact, the brand manager for industry was an alumni of the Cave Hill School of Business. And the head of the Cave Hill School of Business was the one who was managing the negotiations on the behalf of the University of the West Indies. So that made that prior knowledge made the conversation much easier. Looking at their barriers, limited research capacity, they mentioned as one of the barriers. As I said, they were trying to fill this gap, but because they didn't have the research capacity, they could not fill the gap on their own. They also had technical constraints. This is a large manufacturing plant, Pine Hill Dairy. They manufacture and distribute throughout the island chains. They go as far as this tri-state New York area. They're on the cruise ships. They're on the airlines. So they do big batch productions. So every time we have to get a liter of this shake, they have to stop production, do this, wipe the machines. So having to do this multiple times became a problem for them. What they need, apart from having this ongoing relationship with industry, they also said they wanted integrated research and development and knowledge transfer because, as I said, they couldn't do this on their own. And they were looking to go overseas for this, but there's no reason why the UWI can't provide this for them. So that was the inner setting. So now looking at the outer setting, we had very positive, supportive climate and policies. In Barbados, the government has just, the Ministry of Health has launched or relaunched several food initiatives. So we've just redone the food-based dietary guidelines. We've implemented a national school nutrition policy. A few years ago, we implemented a sugar-sweetened beverage tax. So all of these healthy kind of foods movement is in keeping with this low-calorie shake. And not only having food movement, but we have a national innovative thrust. So we have the Minister of Innovation now going into schools. So the two of these together are in keeping with the project that we have. So with the climate is very, very supportive. However, the barriers for industry were the wait times. Even though they had this pre-existing relationship with Tetra Pak, they still had to wait. So if they didn't have a relationship, it would have been a longer wait. And then the risk for importation and wastage. So if they're bringing a particular pulp or a particular powder and it isn't the right consistency or the right taste, then they risk having to throw that away and start all over. So we have this I2I framework, Innovation to Industry Framework, which offers a structure for innovation and commercialization. But it's just that, it's a framework. How it is operationalized is governed by the unique perspective and situation of your particular project. And it's not just for innovations like tech innovations, it can be applied to anything. In the last minute, I just want to pick up on this ongoing industry innovation interaction as it was a common need. So how can we facilitate this? Well, speed dating forums are a common staple now at many scientific meetings, and it's a quick way to explore needs and solutions without any commitment. And you can survey the landscape for new interests. You can meet many people in a few minutes and decide if you want to take it further or not. There are also matchmaking banks where you can deposit your big idea. So it's low maintenance up until the point of contact, and it gives each party time to ruminate and think about it before they reach out to the particular party. The problem with this is that it requires robust IT and ethical protective mechanisms so people are not scared that somebody will run off with their big idea. So I think it's time, though, that we need to move from beyond being opportunistic to creating a culture of innovation. So even though even the speed dating and the matchmaking banks are good for meeting people, it's still opportunistic. You know, you're still kind of bringing something and hoping that somebody likes it. So I think we need to move towards co-creating with industry. So we come with a relatively clean slate. You know, industry tell us what they want. We tell them what we can provide, and we build it together. If it is co-created, you have like 100% chance that it will reach commercialization because it's something that industry said that they have wanted. You're not going in your lab, cook up something, and then give it to them. And I just want to leave you with this quote from the Vice Chancellor of the university, who said this at a recent council meeting, maybe 2 or so weeks ago. That strong, intentional partnership between universities and industry is critical for economic growth. So I just want to introduce you to my team, the principal and the vice principal of the Cave campus, the head of the Cave School of Business, our IP manager, and my fellow entrepreneur. And as said, I'm from the George Allen Chronic Disease Research Center of the Caribbean Institute for Health Research of the University of the West Indies at Cave Hill. And our industry partners are Pine Hill Dairy. And for that, I will thank you.
Thank you, Dr. Quimby. We really appreciate that innovative presentation. Maybe one question? Okay.
I was very clear.
You were very clear. Thank you.
So we are moving on. And our next presenter is Chaudhry Reddy. I hope I got the name pronounced correctly. Ms. Chaudhry Reddy, is she here? It will be what?
It will just be mushroom in the soup.
Okay, so,
Counterpart is here with us.
okay. Okay.
Mushroom in the soup.
Blissett.
Listen.
Let me welcome Ms. Blissett to the program, Mashami Blissett. She's going to do a presentation on multimodal AI for early Alzheimer's detection, accuracy, and optimal combinations. She's a student, and we look forward to hear your interesting presentation. Thank you.
Thank you. Imagine diagnosing Alzheimer's disease before it can significantly impair, or rather negatively impair, a patient's quality of life. Well, that is why myself and a representative of my team, that's why we're here today, to bridge the gap between multimodal AI and early Alzheimer's detection. Good afternoon, everyone, chairpersons, colleagues. Thank you for having me here today. What's the problem here? Globally, around 7% of the nation has been said to have Alzheimer's disease, and within the Latin America and the Caribbean, that's going to be rising to about 10 to 15%. And here within Ghana, based on the World Health Organization, that's said to be 0.23%. Now, the issue at hand, you have several stages, 7 in total, but really and truly during the mild cognitive impairment stage, that is where the problem lies, or rather the early mild cognitive impairment stages. This is because there are very subtle changes that physicians aren't able to pick up on simply by using, let's say, an MRI, PET scan, etc. And so that is why multimodal AI is important to facilitate that in particular. Now, why do I say that? That's because, again, I did mention those traditional diagnostic approaches, which would be, for example, using one modality, which I'm getting at just now, in terms of one particular aspect could be, let's say we have cognitive neural networks being utilized, but then the physician goes ahead to utilize MRI data sets. That's just a single modality. Or rather, you equating the mini mental status exam to that of the, let's say, the neurological physical exam. So there are different attributes that we utilize, but it may not have enough of the sensitivity that is required to off the bat say this patient has Alzheimer's disease before it gets worse in the later stages. So that's where the problem lies. So I did mention already that single modality is something that is being implemented even in North America based on the various studies my team and I did see. However, we're taking that a step further to say, okay, we're definitely going to be using multimodal AI. What does this do? Imagine you being able to go ahead, you're taking MRI data sets, PET scans data sets, and also clinical and cognitive data changes along with retinal and CSF biomarkers, which would have like your neurofibrillary tangles or your tau proteins. All of these together amplify, give you concrete evidence that the patient does indeed have Alzheimer's disease, even when there are just really subtle changes that you're able to see. Continuing, again, this is what I just really said, that again, Alzheimer's disease is something that is, yes, a neurodegenerative disease, but it's multi-systemic, it's multifactorial. And so we can't just look at one particular modality. MRI is looking at, let's say, structural changes, such as that of hippocampal atrophy, or rather the parietal lobe having certain issues in the sense of, again, atrophy, yes. And then when we do heat wave scanning, we're going to see where when we do contrast scans, it indicates that, yes, there could be atrophy or there's inflammation along in those particular areas. Great. Now, what would be our objectives? Or what were our objectives when we looked at this? So really and truly, what is the relevance, right, of multimodal AI in the early detection of Alzheimer's disease? Looking at its accuracy, and then, of course, looking at the optimal modality combinations. There are different modalities, and then really and truly for accessibility and its application or applicability, right? What would be the cost-effective approach? So the study design that we did do a systematic review. Again, I am in the basic science course, and so it was quite difficult at that level to go and get, let's say, data directly. So what we did a systematic review. And we did go ahead and utilize PRISMA guidelines, which is a systematic counterpart. They go ahead and they tell you this is the criteria to make sure that it's internationally standardized. So that stands for the preferred reporting of items for systematic review and meta-analysis. So in terms of the details, we assessed 30 particular studies. Well, we shortlisted them out of the hundreds that we did look at as a team, because I'm just a representative of a team, right? So the databases that we did utilize, PubMed, Scopus, Frontier, for example, and ResearchGate as well. Modalities, multimodal. So these are the few that we did assess as well. So the MRI, the PET scans, retinal and CSF biomarkers, and even that of clinical data. Again, the AI models, they are cognitive neural networks. Deep learning systems are just another way to help you to understand that this goes and is going to be integrating a series of data, has pattern training, and that is how over time, with access to a lot of these databases, it's able to give you as a physician a better chance at diagnosing these patients earlier. So we looked at 3 outcome measures. That was the accuracy, the area under the curve, as well as that of sensitivity. Now, to be short and precise and to drive home the message, the accuracy in particular was to look at the correctness of the model. Is it a case where if we use cognitive neural networks, how sure are we that patients are going to be able to be diagnosed early on, right? So based on the studies, we did see multi-stage cognitive neural networks did indicate about a 98 to 99% accuracy. And this was from some reports that we did see in the USA as well and the UK, yeah. Area under the curve now, again, multi-stage cognitive neural networks and multimodal AI was able to ensure that we were able to discriminate what would be diagnosed as Alzheimer's disease versus cognitively neural. And then sensitivity had more relevance in terms of what would have been cost effective as it pertains to electroencephalograms being utilized with the CSF and retinal biomarkers along with clinical data like the mini mental status exam. Now, to quickly look at the results here. So this in particular does go ahead to show us that over time, what happened is that interest grew to indicate that persons were now wanting to see how AI could be implemented with that of PET scans as the data points and be used now to diagnose patients with Alzheimer's disease. And you're going to be seeing a R-squared value of 0.09, which just means a 79% accuracy, or really a positive relationship between the year and now the interest in AI as it pertains to it being correlated with Alzheimer's detection and then utilization of PET scans as a data set for these deep learning models. Now, this second particular figure that we have here, it shows us what the data sets that were being utilized by this international database. It's referred to as the Alzheimer's Disease Neuroimaging Initiative. It's based in North America and Europe. So what they do, they take a series of data points. And what I did, I got one of their latest publications, and this is just an image here, which indicated that, okay, majority of the information that they had, it would have been that the patient would have been cognitively normal. But then we can see where 18% is being shared between that of early mild cognitive impairment and mild cognitive impairment. What does this say? That these points are actually very important and they're actually quite hard to diagnose. And so it's just going to, based on when I was assessing and my group and I was also assessing, we're saying that this drives home the message that this is something as a region we could take seriously, because at the end of the day, we really want to make sure that 0.23% isn't misdiagnosed, or we're not just underdiagnosing, we're actually going to make sure that these patients don't have it. And so how to differentiate is to make sure that even though there are very subtle changes, we can look and say, yes, this patient has this, we can do further testing and help to improve the prognosis before it gets worse, right? We want to decrease the morbidity and the mortality that the patient experiences. Now, this here is demonstrating, of course, what I mean by a cognitive neural network. Cognitive neural networks, again, is a deep learning model. So that means there's pattern recognition, and what it does with the utilization of different data points, we're able to differentiate between what's cognitive neural, what's Alzheimer's disease, and what is the mild cognitive impairment stage. Again, this is just to visualize how best we can go ahead and make sure that patients can be assessed with this here. Again, this particularly just demonstrates that multimodal AI is something that is really effective, and it is one of those things that has like a 95 to 98% accuracy, and so would really want to implement that as a Caribbean region. Now, in summary, right, what I'm trying to say is multimodal AI does go ahead to give us an increased accuracy. And the area under the curve, meaning it differentiates you having Alzheimer's disease versus non-Alzheimer's disease patients. It does so to make sure that we can improve the prognosis, have the better detectability, and decrease the morbidity and mortality. What is cost effective? What could be applied for our region? Thank you. Wrapping up, right? So what could be applied for our region is that cost-effective models such as the retinal and CSF biomarkers, along with our electroencephalograms being supported, of course, with the AI, that could also be implemented, especially for low resource settings, until we could incrementally improve as a Caribbean region. Thank you. All right.
So, thanks. Are there any questions to the researcher?
Good afternoon. I work for the Caribbean Institute of Nuclear Imaging in Martinique, and I'm interested to know if you consider using PET MRI for this study, because you know that there is an equipment, the PET MR, which gives similar information as what you could get using MRI plus PET. Why didn't you use it in your study? Is it because the equipment was not available, or would you consider using it for the study?
Okay, that's a great question. So what I tried to do, along with my teammates, we wanted to make sure that whatever we had was just succinct at the point, but we did have it in terms of the papers that we did access as well. So that was included in the study. So that's where the whole concept of multimodal AI comes in, because imaging modalities do include that of MRI, PET scans, CSF and retinal biomarkers, because again, that's a form of clinical data. But yes, PET scans were also included in the study. And when we say, multimodal AI, to see the biochemical changes as well, right? So hypometabolism, let's say in the parietal cortex, for example, that as well, we did consider it to make sure that we had a good basis on the understanding of this study. Yes.
But just to clarify, because I know you use the PET CT and
Yes.
you use the MRI alone, but
Yes.
did you use PET MR? The
PET
equipment
MRI?
which combines both? Because there is an equipment which exists where you have both a PET CT plus an MRI in the same equipment.
Okay.
And then you get functional plus metabolic information at once.
Okay.
We do have it in Martinique, and I would be really happy to share this information with you to pursue your study, maybe because we use a specific radio tracers like DOPA to detect Alzheimer's disease.
Okay.
And with the information we get, I guess that this could really complete your study to go a step further in the detection pathway and to combine it with the AI information you got from your study.
Okay, thank you. Yes.
Thank you for your presentation. How can you realistically correlate the multimodal AI into the low resource setting as like our Caribbean country?
Okay, that's a great question. So multimodal AI tends to be quite expensive in its implementation. And so I believe that what we could do as a Caribbean region, we could do a systematic approach. So what we could do is incrementally at first, again, we could make sure that we perfect as physicians, of course, perfect our mini mental status exams and our neurological physical exams. And then we further improve that with CSF and retinal biomarkers. And then we could use AI with those as well, because what we're doing then is using more so a hybrid model. And let's not necessarily say multimodal AI there. It's more so multimodal AI model in that setting. We could do that instead until we have the resources for that.
Much appreciated. Thank you.
All right, our next presenter will be Dr. Lyndon Tellisford. Dr. Tellisford is the Associate Dean and Associate Professor of the Department of Public Health and Preventive Medicine at St. George's University in Grenada. Her presentation today is on digital health innovation for cancer prevention and support, insights from the Caribbean Cancer Portal.
Okay, thank you very much, Madam Chair. And good afternoon, everyone. Well, it's evening already, so I'll try to keep it very short. So this morning, in all of the presentations that were made, you may recall that there was a lot said about digital technologies and the need for us to scale up in the Caribbean region. We must commend the countries that have made so much progress thus far. The Caribbean Cancer Portal is one such technology that we are using in the Caribbean to ensure that we can share information related to cancer. Now, the portal was established in 2021, thereabout. It was supported by the Pan American Health Organization to set up this portal. Importantly, you would understand during the period of COVID-19 that cancer patients were severely, significantly impacted in terms of accessing services and so on. So we did have a quick conversation with some cancer patients, and we noted that many of them expressed the need for continuing education, those that were in particularly newly diagnosed with cancer and needed to better understand how they should manage the disease. We also found generally in the Caribbean region that there is not sufficient information shared with the general public on cancer prevention. Information is present, but may not be accessed by people. And so the Caribbean Cancer Portal was established at that time with the support of the Pan American Health Organization by the Windward Islands Research and Education Foundation, that's WINDRIF, that is based at the St. George's University. And in essence, the portal provides a space where cancer patients can interact with each other. It also provides a platform for disseminating prevention information. It also provides a place to harbor data and research around cancer, and this is something that I think we really need in the Caribbean region, and also a place where patients, people who are impacted, their families, and those that are not impacted maybe can also engage in activities such as exercise programs. You can have some demonstrations there as well as games and so. Not everything has been rolled out as yet, but to let you know, and I think some of you may have interacted with the portal, the education component is very active and we deliver live sessions very regularly. So just to give you a sense here of what we did. Now, it is important that as we roll out programs, as we talk about digital technologies in the Caribbean, we need to also look at the impact that those programs are having on people. And that's something that we sometimes lack. We roll out a lot of programs, but we do not evaluate. And in some cases, we evaluate and we do not report on the results. So in this case, we used a systematization approach to understanding how people were engaging with the portal and how it was impacting on their lives. I think I'm a little behind, yes. So this in itself, understanding what works and how it works brings in, or this is an application of implementation science. So as people told us their stories, this year represents the application of implementation science. And we were able to capture responses in three key areas. One, looking at how we were improving practice and policy in the region. Two, the effect of translation of the improvements that were made, and thirdly, flexibility of the program. So we're going to categorize the responses under these three headings, and there are 5 quick lessons that I will share with you. So first of all, you would note here that and this is one of the key lessons that came out of the portal implementation. One is that there is a need, if we ought to sustain digital technologies in health, we need to ensure that there is a diverse, inclusive, strategic partnership established. And this should not just be at the local level. It should encompass the region. So in the Caribbean Cancer Portal's case, you would see at the bottom of the slide there that we have formed or established partnerships with ministries of health, also WINDRIF, academia in this case, organizations that are delivering care, right? Cancer societies at the grassroots levels. So we have established some kind of relationship with all of these organizations to ensure that we can indeed deliver care through this partnership. But secondly, we should also maximize the resources that are available. There is no need to reinvent the wheel. So already there are a lot of resources existing in the region, and we can maximize. So in the case of the Caribbean Cancer Portal, we do not, for example, pay for delivering content on the portal. Everything is delivered through volunteering. So people work together. The Ministry of Health contributes, the private sector contributes, the cancer societies contribute, and this is how we're able to amass content for the portal. Then now looking at effect translation of improvement, we do not want to keep the information for ourselves. We want to ensure that the information is disseminated and shared with others. So we want to translate improvement. So we want to here build on prior knowledge. What people already know, we want to build on that. So as we bring in this multidisciplinary team, we're able to draw knowledge from different places, different spaces, and we are able to now share and help others to improve. Now, in doing so, we are also applying scientific concept, and we have to be careful with that here. Sometimes we do things and already there are models out there that can guide us to be very effective, but we fail to apply those models. In the case of the Caribbean Cancer Portal, the sociological model is very much applied. We work at the individual level, so we have programs that target individuals. In those cases, we mobilize and encourage certain groups to attend certain programs. But we also work at the community level. So in some cases, we have, for example, survivorship program where cancer patients come together and they're able to share information with each other. And of course, we also work at the higher strategic level with the ministries of health. The next point is very important. Develop need-focused intervention. People should also feel the effect of our programs. But the only way they can do that is when the program has been developed to meet their needs. And so, again, the start of this program was from during the COVID-19 period. We recognized that there was the need to provide information and to continue to support cancer patients. But we also recognize the wider need in the Caribbean, the gaps or the lack of cancer education, especially for prevention. So our program came out of that need, or was born out of that need. Thirdly, we have to talk about flexibility in approach. And here we see that as we do the programs, as we implement programs, we need to ensure that there is room for change. The landscape, the health landscape is changing, and whatever technologies we adopt, we must ensure that we are ready to receive feedback, we are ready to make change so that we can ensure that the programs are tailored or designed to meet the current context as well. So we had some surveys delivered via the portal, and we allow people to just provide feedback, but we captured that information and use that information to build the second phase or develop the second phase of the program. So people felt that they were a part of the process. They felt that the contributions were meaningful. And this is very important. So always ensure that we have that aspect built into our programs. So in closing, again, 5 points that I want you to take away from here. As we apply digital technologies in the region, we need to ensure that there is inclusive partnership, shared resources, need-driven interventions, the application of scientific frameworks, and ensure that stakeholders have an opportunity to provide feedback. Thank you.
Thank you, Dr. Tellis-Ford. Is there a question or maybe two? Up there.
Hello, my name is Camille from UWA Cave Hill / Ministry of Health and Wellness in Barbados. I really enjoyed your presentation. I work in the NCD unit, so non-communicable diseases unit, so this really hit home for me. My question to you was, I know this is like a cancer portal, but I want to know if the framework of this portal can also be applied to other entities, because I saw one of the persons you would have consulted or one of your partners would be like chronic disease management programs. So I just wanted to know if for a person who has diabetes or like a community of people who have hypertension, can this framework also be applied to them?
So in the process of developing the Caribbean Cancer Portal, we consulted with a number of people, and you would notice that one of the partners there is the Grenada Chronic Non-Communicable Disease Commission. This is one of the organizations that is also partnering with us. We have received requests to extend the service to other non-communicable diseases. I think the engagement has been so rich on the platform that we think that we can also have an impact in terms of reaching, providing information to target other non-communicable diseases. Now, when we speak about cancer, and that is something that we pay attention to, cancer cannot be addressed in a vacuum. So we have looked at how cancer can be impacted by environmental conditions. We have looked at behavioral factors. We looked at how other diseases can actually, exacerbate or influence in some way the outcomes of people, affected with cancer. So yes, the answer is yes. People who may have other kinds of health problems can also benefit from accessing the information on the Caribbean Cancer Portal. The information is not just strictly about cancer, but we looked at all of the other factors. You would find resources there that relate to other factors that may in some way impact the outcomes.
Okay, and how do people access this portal?
Oh, thank you. So it's CARIBCAN, CARIBCAN.org.
It is like open to anyone. Well, open to
Yes,
anyone. Oh,
yes,
amazing.
yes. So there are some activities, for example, if they have a closed session for cancer patients, they will recently we had something for metastatic breast cancer patients. The organization, and by the way, the portal is open to the Caribbean people. So anyone can say to us, we want to use the portal for a program. This portal is for the Caribbean. So organizations come to us. The program is not organized by the CCP per se, but it's organized by another organization. So they may choose and say to us, during implementation, we want to keep this private, but once the implementation is done, we edit the videos so that people's identity is protected, but the information is still shared.
Great, thank you. A quick announcement for the room. Apparently someone has lost or misplaced their government ID. So if you look around your spot and see one, if you could bring it to the chairs, if you happen to find one, that would be terrific. Second, there's a lot of interest obviously in digital tools and AI, and we mentioned that tomorrow the Guyana Ministry of Health, along with us at Mount Sinai, we're hosting a seminar on turning promise into practice, integrating AI into healthcare. If you want to attend and didn't already see that, there are some forms up here as well.
Thank you
Thank
so
you.
much.
Thank you very much.
Just a quick announcement. Before I introduce my last presenter, there's a chance to win big if you evaluate the CARPHA conference. What you do is you go to the back of your card, you scan this, you enter the number on the front of the card, complete the survey. If you want CME points, you can get CME points at that time, and you click submit, and that allows you a possibility to win big. The last presenter is a medical student, Bindu Valdilivu, who will be doing a presentation on artificial intelligence in healthcare, ethical integration and impact on clinical practice.
So it's actually
The presenter is Nishogna Intaji.
yes.
Thank you.
Good evening to one and all present here. I thank you for the opportunity allowing me to present. Now,
How do you have the names from? I can't help.
my apologies for what has happened. Now, why was this study needed? As we all know, we are currently witnessing a gold rush when it comes to digital and this technology of AI. So as we see, the AI is getting developed in an unprecedented pace. You name it, from radiology, oncology, surgery, anything you name it, in the field of innovation of medicine, we can see this AI has been developing every single day. But who's going to use this AI? It is us, the clinicians, the students, the researchers, and so forth. But are we ready to embrace this AI completely? Do we have a complete framework that we can work around with? Are we ready to embrace the AI, which could possibly change or give a lot of benefits to us? I believe there is a significant gap in this thing, so that is why this study is needed. Yes, the study objective. We have two clear objectives. First, to analyze the current literature and what is given in these things. The current literature says about how this AI is currently there, what are its clinical integration, and what are its impact in clinical practice as well. Second thing, we wanted to assess how the real world professionals perceive AI as well in different countries. And how was this study conducted? This is in three process. So first one is the study approach. We managed to do a narrative review, which is a mixed review basically. First, we were looking through the data that we found, the quantitative data that we found in PubMed and as well as Scopus. And we also analyzed the quantitative data that we got from the survey itself. Now, in the literature search, as we see, I only chose two particular databases, which is PubMed and Scopus. And the inclusion criteria that we chose was, it has to be from 2018 to 2024, as well as it has to be English language literature only, focusing upon the themes of AI in healthcare, AI in ethics, and AI literacy. Now, on the survey, we have managed to send the survey to different countries, especially focusing on Guyana, India, Russia, and the Middle East. And we have sent this an anonymous survey that we have created to only healthcare professionals and medical students, as well as medical teachers. Now, the survey participation and data collection. So we formed a questionnaire based on the topics that we were able to find in the qualitative insights of the research that we have conducted. And we also make sure that this is completely anonymous, and we also make sure there's a voluntary participation as well as an informed consent. To maintain the highest level of privacy, we did not ask on personal identifications. Now, the key findings from the literature, we have managed to do it in two parts, benefits and concerns. Starting with benefits, there is an improved diagnostic accuracy as well as it supports preventive analysis, which is basically we can find the particular disease early on and catch it and cure it before itself, or give any other ways to slow it down. Now, and one of the main things when it comes to AI is really good in repetitive tasks, so that we can leave AI to do the documentation work and you can focus on clinical aspect. That saves more time and we can have more output for a single physician or any researcher or whatever you're doing on it. And telemedicine, access to care in places where there are less resource or resource constrained area. This is a huge lifesaver, and telemedicine is important. We have already seen a previous presentation on it. Now, regarding concerns are equally strong as the benefits that we see. In concerns, we are focusing on the first thing is bias. The models that we see now are currently trained on particular population. It is Caucasian as well as Asian population. When it comes to Caribbean, there is no huge amount of data that's particularly trained upon. So there can be an error when you give a particular diagnosis, which is given by the AI itself. And limited explainability, which refers to if the AI is unable to conclude that this diagnosis which is given is not a proper diagnosis on how it came to the conclusion, that makes sure that we who are going to use it are not going to trust it, and our confidence in AI is not going to be there, or it's going to plummet so down. Now, the most important thing is data security. Who's going to control the data? How will the data will be controlled? And how the privacy could be managed, and other ethical framework that needs to be happening today. And we also need proper clinician oversight as well as regulation to make sure that we can use AI as a co-pilot. Now, based on the survey results, we managed to find some key findings, which is adaptation as overpaced trust. As you can see, 65% have been using AI day to day, and 70% of the participants have been following AI's recommendation. Not everything, but specifically, and they give a thought about it. And finally, only 44% trust AI in system. So what is interesting is that 70% of the people do give a thought about AI's recommendation, but only 44% are actually willing to trust the AI. So what is the conclusion is basically is people are currently using AI. They acknowledge that it is efficient and it saves a lot of time. But do you completely trust it? No, that professional trust between AI and the professionals who are currently using it is not there. So that's a key finding. Now, support and replacement. So 52% are actually comfortable in using AI, and 63% have said that the AI gives similar judgment to humans. Note that this is only on specific tasks, not on every single factor. And 26% of the physicians actually believe in the near future, AI might actually replace us physicians. So what is another key finding is that AI can still be used as a co-pilot, but not as a replacement tool, which can save us efficiency. I believe one of the main reasons that came here is about especially how AI is very good at repetitive tasks. An example would be, let's take in radiology. So if a particular AI model is trained on chest X-rays, focusing on specific disease, it could be like, let's say TB, it is able to read thousands in few seconds, but a radiologist takes his own time. So those are few specialties where it won't be replaced, but rather it could make sure the workforce is actually decreased by a lot. So that is my thought upon it. Now, as we are nearing the conclusion, so now implications. The first implication is transparency and clinician oversight. It's an absolute and non-negotiable factor. And training and AI literacy. AI literacy is very important, as we say, because what's the use of having a tool if you're not able to use it efficiently? Even a simple prompt that we are going to give can make changes on how the output is given to us. Now, finally, the future directions or longitudinal studies should be conducted specifically in the Caribbean area. Example, in Guyana, we have electrical health records. So we can gather the electrical health records, make sure the model is trained upon this specific data so that we are not using any Caucasian data or data from the Asian sources. Making sure that AI is specifically very accurate, because if we were to use a data from an Asian side, like let's say it's specifically on sickle cell anemia or any hypertension, there's a chance that this AI could possibly make a misdiagnosis. And if you were to trust this AI and say this so and so, you are responsible for the error that has happened, and AI or the developer cannot take responsibility for it. Next, we also need to see these studies to be conducted in real world clinical impact and make sure to ethically and clinically create rules and policies, such as examples there in United States, such as HIPPA, where if you were to make a mistake by making sure that you don't have proper data privacy, the doctor could be possibly fined for the mistakes you make. And we can also adopt the WHO regulations for the AI practices. We can use it currently, but even it's not concrete, but we can use it as of today. And the limitation in the survey that I have conducted is self-reported survey data and the descriptive design itself, which limits the generalizability. And we have also not made a very broad spectrum database. We are only limited to PubMed and Scopus because I didn't have access to other databases, but it's my problem. And as we say, AI has immense potential, but if there isn't any framework that we can work around with, that makes the AI redundant. So I believe we are running towards a future where we can embrace AI, not as a replacement, but as a co-pilot. Thank you.
Thank you. Is there a question from the group?
I have a comment. Hello, good afternoon.
Good.
So for someone who's a general practitioner with an interest in bioethics in public health applications, I do want to make a comment as it relates to the importance of also including policy, regulations, and governance in this aspect. I know that your work is just focusing on responses from physician and healthcare practitioners. And so I think it would be good to understand that usually they are not the ones who put the regulations and the frameworks in place, but they should be consulted. And I really appreciate the approach of AI as a co-pilot, not replacing the physician, because really we cannot replace that physician to patient contact and the value that that provides in healthcare. But standardization of the AI and the software that we use, along with regulations, I think is always the ethical way to go when the policymakers are at the table, but also the physicians who are going to use it. And your point about AI that applies to the local context and the cultural settings is another very important ethical consideration. So very good presentation. Those are
Thank
my
you for
comments.
adding that point, ma'am.
Thank you. Any last comments or questions? All right,
Yes,
terrific. Sorry?
Yes. So hi, that was a great presentation. As you said, you were a medical student. Do you think you should apply or include AI literacy into preclinical curriculums in med schools?
Yes, absolutely, I believe that is true. As I said, as simple as prompt creation can change. let's say that you're facing let's say that you're using again for AI or any ChatGPT itself. Let's say you're facing a 50-year-old male with type 2 diabetes. You're just going to type this thing and say how to treat it. And the output of the model that has been trained upon is going to be less. So rather, we can focus. A simple example is, let's give it a role. Let's say that the AI is an veteran a veteran doctor, a veteran internal specialty, medicine specialty, and let's give it a action that I wanted to frame so and so. Like, for example, the treatment that is given here for the type 2 diabetes based upon the verified data on so and so databases that is available, and you have to give your own context that I'm a doctor that is using you as a co-pilot. And finally, you can give an execution that I want you to give me certain points on how I can treat this exactly. This is a way that we can structure the prompt to make sure that we have a high efficiency output rather than giving a non-structured way. So that's one thing in prompt generation. And we also need to be aware that AI can hallucinate. It can give clinical data on its own without being verified. So it's up to you to learn whether this data is actually true or not. And second thing is, AI cannot explain properly. So you have to learn and understand when this AI could be truly useful and when it is actually wrong. So that makes things easier for us to learn if it is implemented in early stages of the medical education itself. That was a great question.
Thank you so much. Excellent. All right. Well, with that, we conclude our session on innovations in healthcare today. As Dr. George had mentioned, you have a chance to win by completing your conference evaluation. And I believe there are also buses to take people to the opening ceremony.
Yeah, thank you, Chair. Thank you. Thanks also to Mount Sinai for sponsoring this session, Innovation in Healthcare. Thank you for chairing, and thanks to all the speakers. So this session is now closed. Today is finished, and the buses will take participants directly to the opening ceremony, which has been hosted by the Government of Guyana, Ministry of Health, Government of Guyana. Very exciting program, I assure you.